Hello and welcome to this episode of Coding Matters with a Vascular Focus. My name's Andrew and I'm joined by Peter Subramanian. Peter, what's your role and background?
So thank you, Andrew. It's great to be part of this important element. I'm a vascular surgeon, as you know, and I also have a management role as lead in one of the surgical streams. And for the time being, I also have a role in a national organization. I'm privileged, really, to be the president of the Australian New Zealand Society of Vascular Surgery. And the reason I bring that up is because in this focus, we're really talking about vascular surgery and documenting how we manage it in our hospital.
Absolutely. So some of the themes that if you've watched some of our other videos will come up again, but we're really going to drill down on how they matter to vascular patients, whether they're directly under a vascular team or whether they're in the hospital for another issue and vascular events occur, as they often do at unexpected moments. So we'll talk about the link between quality documentation and those patient outcomes. We'll get very specific about the terminology that we're using in our documentation and how that enables the best quality coding. We'll talk about manifestations of disease and complications of that disease and associated conditions, because they play a very important role in the presentation for vascular patients. And we'll talk about how they add to complexity as well. So Peter, tell me about how precision and quality documentation matter to you in your role.
So I think I'd like to give you a little bit of context. Vascular surgery has changed the way in which we deliver it in the last 10 to 20 years. We've gone from being an open specialty to a very endovascular or minimally invasive specialty with a huge input. With our ability, our tools have improved due to the innovation in technological advances. That's not changed the disease we've treated, but it's certainly changed the way in which we administer treatment to patients with vascular disease. And so that documentation of generic, if someone has a bypass, now they to revascularize the limb, they may well have multiple interventions. And it really is important for us to document that intervention. Now, today's focus is, of course, ensuring that we document it in a way that our coders can capture the activity and we get adequately funded. But there's another important reason for documenting what we do, because that's a record of the activity we've performed. It gives us a look at what we've done, how well we've done it, and importantly, gives us a database for which we can measure improvements. So it's a fairly long-winded answer to your question, but in vascular surgery, like with a lot of surgical subspecialties, many innovations have developed, and we need to be able to capture what we're doing with those innovations.
So just as a reminder, if this is your first time to a Coding Matters video, the elements that make up clinical coding are the principal diagnosis, which is the reason for admission to hospital on retrospective analysis. So they might have presented with a certain presenting complaint, but that led to a diagnosis. And it might be very clear, such as presenting with infection and cough and being diagnosed with pneumonia. But for some people, they presented with a fall, which led to a diagnosis of a stroke, and it wasn't obvious that that's what it was at the time that they presented. There are secondary diagnoses that arise during hospital admissions, as we all know, along with complications and procedures as part of treatment for the principal or secondary diagnoses. And there are comorbidities that pre-exist before they come to hospital that contribute to complexity. So all of those will result in a disease-related group and a level of complexity that will then inform performance measurement, audit capacity, as well as, of course, funding, which is activity-based in Australia. These are the essential elements, so the assessment of the condition, so the objective and subjective features of it, the diagnostic or interventional elements that help us work out the diagnosis and a statement of that diagnosis, and then a care plan to address the diagnosis. So chronic limb-threatening ischemia, that would be a pretty common issue for people to present to your department.
Yes, Andrew, and I just want to say, I think you've captured in 2 slides before exactly the sort of issue that you have with a vascular patient. Let's take this patient, the chronic limb-threatening ischemia. Now, this patient may present with rest pain or with tissue loss. or maybe with short distance acute onset claudication. All of these are elements of one diagnosis. However, their manifestation has to be documented for us to be able to understand, not just from a coding perspective, but also from data capture for activity, what sort of presentation. And they vary from a benign, small ulceration to someone with critical limb-threatening ischemia with rest pain. It could be a situation where this patient has had a progressive deterioration in atherosclerosis, or it could be an embolic or thrombotic occlusion of a pre-existing stenosis. Really also what you said about the documentation of comorbidities, someone with chronic limb-threatening ischemia doesn't present purely with chronic limb-threatening ischemia. There'll be a background of other manifestations of cardiovascular disease, other manifestations of atherosclerosis, ischemic heart disease, maybe a history of coronary intervention, and of course, as you know, as a physician trainee, the tsunami of diabetes and all the associated comorbidities. So you're spot on when you say that we need to be able to really descriptively capture that sort of patient that we're treating. And this is a prime example of that, the patient who presents with limb-threatening ischemia.
I think it's easy in the busyness of our work schedule to get caught up in saying, this person is presented with occlusion of a specific vessel, and then we miss out by saying due to, or as a manifestation of peripheral vascular disease, due to atherosclerosis, due to poorly controlled diabetes. We know it's there, and sometimes we make assumptions that we don't document, but if we don't document, we're missing out on what is truly happening and that being coded appropriately.
All of these are not just comorbidities, but they're comorbidities which are active. And we know that if these active comorbidities contribute to the complexity of the patient we're treating, we need to be able to document that. And I think as we're going to go through some of the examples, you see that the capturing of this actually has an impact on activity-based funding and what we get funded for as a hospital.
So this is just a quick cheat sheet for those people who don't present saying, hello, my issue is that I've got chronic limb-threatening ischemia. That would be kind of convenient in some level. They present because there's a complication from that ischemia. So is it with gangrene? Is it with rest pain? Is it with ulceration? Is it with claudication? It could be with all of the above. And stating that is really important because that contributes into making sure that we've got an accurate diagnostic workup and accurate coding to support our funding as well.
Completely correct. And it's not just coding, it's good medicine. It's the way we communicate with each other. The more accurately we communicate with each other, the better we are in terms of devising that care plan that you talked about after diagnosis is achieved.
So here's an example in terms of complexity. We'll go through a few others like this. So there's a 55-year-old female patient admitted with 4 days of chronic ischemia of the leg, and this proceeded to an angioplasty with insertion of a stent. And that would be quite common to document that. That might be what you've written on your problem list, and you would get almost $8,000 reimbursement towards that. As opposed to if you documented the same thing and you documented the rest pain and ulceration that was present at the time of presentation, then even though the management is the same, we've actually increased our complexity and almost doubled the income for that one, which is probably more reflective of the actual monetary resources being invested in that patient's recovery.
Yeah, correct. And I can also say that in documenting that the intervention was for rest pain, it also gives us an idea that if the intervention fails, and we would recognize and code for that the consequence of that is a higher risk of limb loss. So not only does it demonstrate the complexity of the patient, but that clinical description gives us a more sophisticated way of follow-up and managing the patient.
Yeah, much more clinically significant to be aware of that.
Correct.
So peripheral vascular disease, we talked about associated issues previously, and so it's very common when you don't have good perfusion a lot of problems occur because perfusion is so essential to all of our tissues. So it can be infection, which can be as, I'll say simple, although that can still be quite severe, as cellulitis and describing where exactly that is, versus a more severe infection like osteomyelitis, which it becomes probably the actual issue in itself. There could be embolism, thrombotic complications are very common in the vascular. I mean, outside of hematology, where we love to manage a good clot, the next key partner is the vascular team, where you guys managing clots, particularly from an arterial perspective. And then that can result in sepsis, maybe that's septic shock, maybe going to intensive care, ulceration of many different types, whether it be neuropathic, venous or arterial, and varicosity, which is obviously a common issue. And really, talk me through skin ulcers, because I bet I could learn one or two things about skin ulcers. What are the things that we should be writing when we're describing these?
So an ulcer is a breakdown of the tissue overlying, an intact, part of the body, skin. So the thing about it, the ulcer itself is a description, but the reason for the ulcer is really where the money is. So it's a diabetic ulcer. It could be a venous ulcer with evidence of chronic venous stasis, past history of DVT, post-phlebitic, but that may also coexist with someone who's a diabetic or someone who's a ex or current smoker who's got active arterial disease, so you can have a complex mixed etiology ulcer. So you've got a list of things there that provide description, but a lot of our ulcers are multifactorial, and we need to describe it, and it's quite legitimate to say that, in someone with a mixed etiology ulcer, they've got more than one pathology which is active. That needs to be documented, and that needs to be treated.
And we've talked before about that idea of multifactorial can be almost an easy way out of documentation, where you say multifactorial ulcer, or we talked about that with respiratory with multifactorial dyspnea, another common issue where there are often multiple pathologies at play. You can write multifactorial, but please then call it up due to or in brackets and list the different factors. That's really important. And even clinically it's important because it makes sure that in management that we are addressing, because the management of each of those issues will be unique. There's not just one management issue that will cover all of those contributing causes. So we've covered this before, but being specific in documentation and the way that we describe symptoms and signs, and then linking that with descriptive diagnostic terminology is so important. It's such an easy way to improve our documentation. We should be doing it, and we would like to be doing it better, and we hope that you'll take away some of these points from this video. So here's some common examples that you might see in vascular patients. So, low BP, that's an observation, that's not a diagnosis. If you then say hypotension or postural drop is a diagnosis or an observation, that's an observation, that you need to then put, postural hypotension or orthostatic hypotension. Writing their creatinine is perhaps helpful for you, but you're making an assumption about how we interpret that. Just write your interpretation. Is this acute on chronic kidney disease? What's the stage of the kidney disease? Helpful to consider with drug dosing, particularly clinically. And then there's some that are very specific to vascular that we've listed there as well, Peter.
Yeah, so hematoma, hematoma doesn't come of itself. A hematoma due to a femoral puncture performed to introduce a stent or perform a recanalization of an occluded artery, etc. And then due to anticoagulation associated with the need for anticoagulation. So the hematoma is a description of a condition, but what we're really wanting to be able to document is this hematoma is due to the fact that we performed a peripheral intervention through a femoral puncture, and the closure device may not have deployed accurately, or the patient needed to be anticoagulated and developed a hematoma. So that's very specific to vascular. I'd be encouraging all my junior colleagues who do rotations in vascular to actually take heed of that. The other thing, of course, is the complication of our interventions. A stent graft that develops an endo leak for an aortic intervention, or a peripheral intervention, a femoral stent or tibial angioplasty that occludes after, that needs to be documented. And I think that's very specific to vascular, especially, as I said a little while ago, because we have so many new minimally invasive interventions. They're not visible. You don't see wound dehiscence, or you don't see, necessarily, a graft sort of bleeding. Because they're hidden, I think sometimes we don't document that well. But I think we need to. I hope I've made that point, that there are very specific complications associated with specific vascular interventions. It would be the same for other specialties.
Absolutely, yeah.
Need to be documented.
Even skilled technicians will still have complications. There is no perfect procedures that gets it right and has no complications every time. And so we have to be transparent around when there are complications, managing them appropriately, and that will feed into hospital-acquired complications, it will feed into our funding, and it feeds into our performance. And so we might find our complication rates are actually ahead of the average nationally, and that's a good thing. We can pat ourselves on the back and then continue striving to do good work, but maybe we'll find we're a bit behind, and then we need to actually look at the reasons for that and that professional accountability to say, individually or as a unit or as an organisation, what are we going to do to lift the bar towards the acceptable standard for our patients?
I think you're correct, and I think it started off with our earlier comments that the documentation is not just for us to maximise our income. It's really for us to understand what we're doing, how well we're doing it. In vascular surgery, we have the Australasian Vascular Audit, which every vascular surgeon who's a member of our society contributes to. So we have a national benchmark, and it's really important that we ensure the integrity of the data going in. So recording those complications not only describes the complexity of the case, but it also helps ensure the integrity of that national benchmark based on the data we put in.
There are a number of additional diagnoses commonly associated with some of these common diagnostic-related groups, so skin ulcers, cellulitis, skin ulcers with peripheral vascular disease, venous ulcers and diabetic foot. So you can see them listed there, and we hope that can serve as a bit of a cheat sheet. It's not just one. Like most patients that present with these issues will have at least one, if not multiple, if not half the list sometimes, and we need to be clear about documenting them and then managing them with a specific care plan.
There was a retired vascular surgeon, and I'll mention his name, Dr. Ferguson, in fact a doyen of vascular surgery in this hospital, who used to say that the gangrenous toe was the equivalent of a Swansgan's catheter. So you see vascular disease manifestation of multiple other diseases that are occurring, and you've got that fantastic list there, which is so descriptive of many of our patients with chronic limb-threatening ischemia. Not only do they come with gangrene, they may have the diarrhea associated with long-term oral antibiotics administered in the community. They may be dehydrated, and as a consequence of that, they've got acute kidney or acute on chronic kidney issues. They may be decompensated because the gangrenous foot is associated with an infection, and they've got septic impact on cardiac function, so they've got chronic, so it just goes on, Andrew.
Yeah. Do you want to talk us through this example?
Yeah, good one, this one. And we talked about it a bit earlier. A 60-year-old with 15 days. That, of course, is the reality. And unfortunately, it's all those other comorbidities that keep patients in hospital. But you notice that in the description in the top end, we talked about an ischemic foot, cellulitis, toe, necrotic ulcer, and then we had a description of a blood pressure reading, 90 on 50, and the patient looked dry. Now, the coders are going to look at that, and it does not have the low blood pressure being defined as hypotension, and importantly, that the hypotension was due to the fact that the patient was dehydrated. That absolutely changes their complexity. And look at the quantum that is, that we've changed the minor complexity to major complexity. And I think you and I would agree, we are not gaming the system. We are actually describing the patient that we treat every day. And the patient that we treat every day in this hospital and many other hospitals of our size are complex patients.
We're spending this money,
yes,
and we're usually getting reimbursed a portion. And so what we're trying to do here is do the best for our patients and make sure our system is sustainable by documenting in order to get the accurate reimbursement that's hopefully close to what we've actually invested in our patients.
Indeed, that's exactly right. We are spending that money, because our focus is on ensuring that we, deliver best care, but we're not capturing the funding that comes with that.
So here are some other complications. We've talked very medically, but here are some that where a lot of allied health may be involved. So issues related to implantable devices. There are a lot of stents and things that you like to put in endovascularly, so this is probably a more common issue. And that's something we haven't talked about in a lot of other videos because there aren't that many specialties that deal with implantable devices. Obviously there's more of them coming along, so grafts and stents are mentioned there. So being very specific about the terminology there, about the positioning, the obstruction, the failure, the infection of those grafts or stents. When they work well, they're amazing and they save lives and they improve quality of life, but they can be problematic occasionally. Wounds, as you said, less wounds these days than there used to be, but dehiscence, hemorrhage or infection of those wounds. Obviously you're dealing with amputations of toes, feet, legs, and then we've got stumps and the nerves to be looking after, and that can be tricky. And of course, antibiotic resistance. There are so many of your patients that are on long-term antibiotics or recurrent courses of antibiotics. Antibiotic resistance is going to be a lot more common in this patient cohort of vascular patients. And all you need to document is just say, this is this infection, resistant to, and name one of the many antibiotics it's going to be resistant to. And that just gains that complexity, which is more reflective of actually what's going on. So here's another example, a 60-year-old female admitted for 5 days, shorter admission this time, with an infected diabetic foot ulcer with cellulitis of the toe. And they've mentioned there's edema and swelling of the arm at the intravenous cannula site. Let's compare that, and here's the difference. It says ultrasound of edema and swelling, so we've assessed it, we've mentioned the diagnostic procedure, the scan, and assessed as superficial thrombophlebitis due to the catheter. So you could make some assumptions, or it's not really clear in the first version. In the second version, again, the same thing has occurred, but we've been specific with our terminology. And although we're then attributing it as a hospital-acquired complication, a HAC, and so we're paying a small penalty to our reimbursement, we've gone from minor to major complexity. So again, being transparent is really important. Whenever we put something through the skin, there are risks of infection, there are risks of clotting and other things as well. So the patient is hopefully aware of that through consent, and this complication which we'll manage has occurred, but actually increases our complexity. So diabetic foot is another, apart from the chronic limb ischemia, is probably one of your other biggest reasons for admission, would you say, Peter?
Yeah, and in this hospital at Central Adelaide, Royal Adelaide and Queen Elizabeth, we have developed a model of care which is multidisciplinary, and Professor Rob Fittridge, who's a world leader in this, having developed this from very earlier on, he is very focused on the fact that this is a multidisciplinary approach. We need our podiatrists, we work with our podiatrists, our wound care nurses, our orthotists, our physios, and also with our infectious disease colleagues. So a truly multidisciplinary approach to manage this chronic problem.
This is a reminder to specifically say diabetic foot and then mentioning what the complications of that diabetic foot, because it will be different at different times. And only when there's a much more severe issue would it be superseding as the main reason for presentation. For example, osteomyelitis may supersede. There may be a diabetic foot which is predisposed to osteomyelitis, and then mentioning the different complications and how allied health are contributing. So podiatry, diabetic educators, and any prosthesis that's being produced are commonly involved in these patients.
So I think this demonstrates your previous point about the osteomyelitis. So if you look at the first description, it's a 50-year-old man with a necrotic toe and osteomyelitis with previous amputation of toe, diabetic foot, and it's coded as a diabetes with minor complexity. But when you bring the fact that the key element here is the fact that this osteomyelitis is not going to heal without a significant intervention, and the fact that the patient is diabetes is mentioned, but the focus here is osteomyelitis, which requires management of sepsis, so infection, management of infection, but also oftentimes revascularization, which is why it goes to significantly changes the funding for this, and it's really the way in which we've said the same thing, but really rearranging the words.
The emphasis.
The emphasis here is on osteomyelitis associated with a more complex intervention.
Yeah.
It's a complex set of interventions reflected on a higher reimbursement.
Same minor complexity, but it just reflects, as you say, osteomyelitis of itself is more complex and more clinically significant.
Yes.
Here's another example where we've got an infected ulcer on a lower limb. Vascular is involved. There's a venous ulcer as the diagnosis and seen by the podiatrist for wound management, $5,000. Probably not quite reimbursing the actual investment over 5 days that's been made in that patient's care. If we then say there was an excisional debridement, so now there's a surgical intervention, and again, as we've talked about in previous videos, please be very specific in your operative notes so that you can describe what you're seeing and diagnosing and describing how you're intervening. That's really important. It's not just being attributed to a MBS code. Excisional debridement and that on the ward by the podiatrist in this case, and you can see that instantly increases the complexity significantly. Now, if we hadn't mentioned the debridement and it's just been seen by the podiatrist, we're missing out on $13,000, which is enormous. And on the last one, maybe there's no intervention here, there's the venous ulcer, but through the antibiotics, we've induced some diarrhea, which is obviously going to intervene with the patient and maybe prolong their stay whilst we're investigating that. And so even that small and perhaps simple addition actually increases the complexity to intermediate, and along with that, the funding. So Allied Health, they play a very important role. Often the surgical element or the endovascular element is often up front, but in order to support the good work that you and your colleagues have done, we really need these Allied Health colleagues of ours to help support the ongoing recovery from the primary issue and the secondary issues that are there, wouldn't you say, Peter?
Absolutely. It's not just, doing the operation and having no complications or surviving the operation. It's about getting better. And, we don't operate in a isolated environment. And that's why we have a multidisciplinary team at our outpatient clinics and on our wards. And we're not the only specialty that does it. And I think, I'd like to call out and really pay credit to our nursing staff on the ward that manage these patients from all these elements, because the podiatrist comes, the dietitian comes, the physio comes, the pharmacy comes, the psychologist comes, or the liaison psychiatry comes, the surgeon comes and goes, but the person who stays with this patient is the nurse. And all these elements of treatment are often administered or overseen by the nurse. So I have to say, modern day vascular surgery is not, because of the complexity of cases what we're able to do, is not about purely the procedure. It's about ability to work in a team to get that final best clinical outcome, which is more than just surviving the operation.
Absolutely. So a shout out to our vascular nursing colleagues. You are a nursing specialty in itself, and we thank you for your work and improvements in the way that we care for patients. Here's an example, a 60-year-old who's admitted for 15 days for ischemic foot, cellulitis and a necrotic ulcer. They've got type 2 diabetes on insulin. Again, we've mentioned here a low BP, and the patient looked dry. Again, what are we assuming but not documenting there? Gave some intravenous fluids, poor oral intake, and referred to the dietitian, and ultimately had an amputation of the toe as their definitive management. And here's the difference, where it was seen by a dietitian and we documented malnutrition, and hopefully we could also correct that blood pressure to hypertension due to dehydration, would be nice as well. But even without that, we've gone up to major complexity and we've doubled our activity-based funding, which again is more reflective of the time and efforts and resources we're investing in that patient's recovery. So to summarise what we've talked about the quality and how documentation reflects the patient outcomes accurately, or should. We've talked about being very specific about linking the causal relationship between the diabetic foot or the infection or the ischemia with the underlying conditions and contributing comorbidities that are there. We've talked about the manifestations of disease and complications that occur, and we've really fleshed out how they add complexity, particularly to some of our common vascular issues. So thank you, Peter, for joining us. I've learned a few things through our conversation, and we'll continue working to improve our documentation.
Thank you.